As a, okay, thank you. And as a background to the presentation, Dr. Umar, which was shared with me some time ago, what he wanted me to share with the association members. And we thought that discussing crowns and fixed partial dentures in clinical practice is something that would be appealing and to the association members, and to just get an update of what is taking place right now in the world, and how you can modify your practice to maximize the knowledge that you have, the clinical skills, and of course, to earn an income. The bulk of my presentation is going to come from material that I have accumulated over the last couple of years, 2, 3 years, while in school here. So in that sense, it's not original thought. And where possible, I'll try to cite the sources of the information, but it's coming from lectures, presentations that I have attended. And I think we would benefit, or all of us would benefit from this material. So, but I hope that this will stimulate a rich discussion, and that this 1 hour also will be worth your Friday evening. I can imagine 6 p.m. on a Friday evening. If I was in Uganda, I would be perhaps tired and just want to get home. So for you to spare time to be here, I don't take it for granted. And I hope I'll make it worth your while. So we're going to start. The rest will find us there. So, as aptly put, we are looking at the choice of material for optimal and long-term performance. And the lecture presentation, or this presentation is going to be in terms of the outlay will be discussing different materials, their advantages or their physical properties, their usage, their pros and cons, and towards the end of the presentation, I will share what I would term as clinical pearls. What can you take out from this lecture that you can use in your practice tomorrow? Basically, what's the takeaway message that I think would be good for you? And I hope it will make you'll feel it's worth it. So I believe most of us are still using metals in our practice in one way or another, whether you're using alloys like amalgam, or we're doing post-infused to metal crowns. We all use some kind of metals. However, with the advent of zirconia, a lot of things are changing. But still, metals play a critical part, and we cannot say we're going to let them out of dentistry. My discussion is limited to crown and bridgework, and perhaps implant or prosthetic dentistry. So the metals that we have used or that we are familiar with in most cases, sorry, what's my presentation? Just a moment. Yeah, sorry about that. So we have used, for most of us are familiar with base, noble, titanium, and alloys. So when you're ordering a porcelain fused to metal crown, most likely they will ask you what kind of metal do you want. You can choose porcelain fused to base metal. You can choose porcelain fused to noble or to high noble or other materials. Titanium is not mostly used in this case. What do we know about base metals? That is your copper, iron, nickel, zinc, and so forth. We know these are common and inexpensive. However, they don't resist tarnish and they corrode. So, as a practicing dentist, this would be good on your bottom line because the cost is markedly lower. However, if you want to give something, these materials are tested and true, so it's not going to change. You're not providing any less service to your patients, but you are definitely saving on the cost, on your lab costs. If you want to use something else, then you might need to consider transferring that cost to the patient because different labs charge differently based on the material that you request for. Noble metals like gold, platinum, and palladium are expensive and scarce. However, they have excellent properties. They resist oxidation and tarnish. And then you can go to alloys. Alloys is a mixture of different metals for the purpose of improving hardness, strength, and toughness. And here you can have the high noble alloys or just the noble alloys. And the difference comes to is based on the quantity of the noble or the alloy itself and gold. So for the high noble alloy, you must have greater than 60% of the alloy and greater than 40% gold. For noble, it's just you must have 25% of the noble material. And then titanium. Titanium, of course, like most of us know, is used in implants. That's the implant structure or the implant material, but as well as the suprastructure, that is for your prosthetics. We know it is lightweight, so it's better in terms of quality of life for patients. It's a transition metal. We know it's biocompatible, non-corrosive, with a high yield strength. So what are the indications? Where can you use metals? So if you are in your practice and you're saying, where can I use full metal or where can I use porcelain fused to metal? Uh, Personally speaking, I have not done a lot of porcelain fused to metal in the recent past. Even when I was still practicing before I went back to school again, I had moved towards ceramic because majorly because of aesthetics and of course there's a lot of work being done in with research and development. So we know that the flexure strength of some of these ceramics is excellent. So, and many of you, if you have practiced for quite a while, you don't like to see that black line that is so typical of porcelain fused to metal crowns. Now, just imagine if that is on an anterior tooth. It's annoying to say the least. So I don't know what your practice is, but there is a shift. And I think most people are moving towards that of using less metal work and moving towards the ceramic. That said, it does not mean there is no indication for this. It is. And where do you have that? When you have limited interocclusal space. So you can't build your metal and then your porcelain. Then you can choose to go for a full metal crown. And many of you remember that gold is strong in thin sections. So even if it's a millimeter, even less, that material is strong. It's not going to fracture, it's not going to break, as opposed to porcelain, which is going to chip. And then, of course, it is not as abrasive as the other materials, so it won't wear the opposing dentition markedly. So when you have long span prostheses, you are better off having a metal core on the inside as opposed to doing zirconia ceramic. In fact, there is a 2018 systematic review that found that the 5-year survival rate of zirconia ceramic fixed partial denture is significantly worse than that of metallic or ceramo-metallic fixed partial dentures. And in addition, they say zirconia ceramic FPDs suffer catastrophic failures more than your metal FPDs. FPDs is fixed partial dentures. So when you're doing long span units, or you're doing 6 units, or you're doing 8 units, full mouth reconstructions, you are safer. If you want to guarantee results for your patients, you might be safer choosing metal ceramic. There are also other indications where you have heavy occlusal forces. You might consider using metal crowns and FPDs. Other indications that come to mind in case of worn dentition. If you have a worn dentition, perhaps this will be a point of another CDE, and you're doing a full mouth rehabilitation, or you're doing multiple units. Sometimes you have to open the bite. And because you're opening the bite, it can be pretty tricky. So if you don't want to open and you want to just keep things the way they are, you might be safer just going for metal crowns at the back. And then you can use your at the front, you can have porcelain facings on top of the metal. And where you have eccentric interferences, so if you have in lateral excursion, when the patient slides to the left and the big one tooth touches, if that tooth is touching on a porcelain crown, the 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 results are worse off than if it was touching a metal crown, because normally the metals are they're thin, so they can be really the patient can afford to do that without any catastrophic results. We know that things have significantly changed, and this is over the last couple of years. So ceramics in dentistry are the mainstay. In fact, a lot of research and development is within this area, and nothing has been done. There's not a lot, the most research that has been done in dentistry is, I think, within this area. And just to get us oriented, I thought I should give us an idea in a table or an organizational chart way of how ceramics can be classified in dentistry. But as I said, things are changing. So my classification might change, might change. They won't change in the future, but there are things that might be slightly different. So if you look at ceramics, we could classify them in 3 ways in this particular table format. You could have your powder and liquid, which gives you your feldspathic porcelains. Then you could have your glass ceramics, which is you have the lucite reinforced and the lithium disilicate. And then you have the polycrystalline, that is your alumina and zirconia. But of course, the bulk of where dentistry is headed in the future, or currently and even in the future, is around zirconia. The other classification is still ceramics. You can do whether it is monolithic being cut from a single block, as opposed to layering, where you have a core and then on top of that core you add feldspathic porcelain. So those are the two kind of classifications that I thought would orient us in our discussion on ceramics. And I'm sure that many of you are familiar with these things. So I hope it will be a good opportunity for us to discuss after the presentation, which will make it richer. So I'm going to discuss these briefly, highlighting the physical properties, their application, and or their indication, and their advantages and disadvantages. So when you talk feldspathic, this is the first of all ceramic restorations that was developed, and it's primarily composed of silicon dioxide. It has high translucence and excellent aesthetics. It's made from natural feldspars, that is your aluminosilicates, and a combination with potassium, calcium, and sodium. Uh, the thickness required for these restorations can even go to just zero point 0.2 or 0.3 of a millimeter. Basically, you don't even have to prep, or you have to do minimal prep and get this fixed. These restorations would what make your veneers stand out. So if you're doing veneers, this is the choice of material that you would go for. And here you can see this is a 1-3, I believe, and they have restored it with a veneer on top. But you can say that the prep is really minimal. Oh no, this could be 1-4 actually, not 1-3.
You've become so American. That's a 1-5.
No, it's not a
I
one
think
five. It's a
so.
1-4. It's a 1-4. Oh, it's a 1-5
Okay.
actually.
Yeah,
1-5.
because I'm seeing the
1-5.
large
Yes.
tooth
Yes.
distal to it. Yeah.
Yeah. It is. The numbering changes a little bit. So, but yeah. But originally, this type of work was done by hand. That is, feldspathic porcelain is built up in layers. So you'd have a technician who will build this up. However, with the change in technology, CAD/CAM, 3D printing, this material can also be pressed or it can be milled. So it's not only just for you. So what happens is that most practices or most people who do a lot of work have work with labs that can mill this. But when they want above or above and beyond what the usual dentist will request for, the average dentist will request for, then for some of this work, you need to have a technician who can actually do layering to give you the natural aesthetics or the beautiful work that you would expect from these porcelains. So my take home would be if you're doing veneers, this would be the material to go to. So what are the pros and cons? As I've already said, this is like mimics natural translucence. So it's like it's your tooth. And if your eye is not critical, you might not even be able to tell that this is a restoration. So your shade or your color matching should be excellent for you to maximize the aesthetics that come with this type of material. And like I've said, it's the most conservative prep design. In the past, you'd be told you need a millimeter for your veneer. But right now, people are going down to 0.5 of a millimeter to 0.3. So all you need is actually to create the margin on just the margin, and the rest is would be done. And they have high wear resistance. However, this material is dependent because it depends on the bonding strength of enamel. If the enamel is deficient, then you're going to have frequent decementation of these veneers, which can become problematic because you don't want a patient coming in every day or every other week to recement a veneer. You might be better off in that case switching to a full coverage crown. I'm sure Dr. Chizito has some examples. There's a patient of ours who had veneer work done, but the tooth structure was devoid over time because of, I think, one of either an amelogenesis or a hypoplasia at some point in time. We they need to do veneers. But because the bonding strength is not good to dentin or to enamel that's not richly mineralized, they kept coming off. So then at a certain point, we had to tell the patient that we might need to move to full coverage crowns of veneers. They require schematic bonding protocol. They are unsuitable in areas with high occlusal forces, so they can only be used at the front, not at the back. They have low strength and they have a high tooth wear induction. So if they are contacting opposing teeth, they are going to wear them down. So be mindful of that. Now that we have discussed the feldspathic, let us go to the glass ceramics. I hope you're still with me. Remember, it is ceramics. You have your powder liquid, which is the feldspathic porcelains. Then we have the glass ceramics and the polycrystalline. In the glass ceramics, we have two that I am sure most of us are familiar with. You have the lucite reinforced. And many of you who have worked with Dr. Tom, like I'm sure almost of us have, you have your Empress card made for CEREC. So Empress card and Empress multi. Those are two things that are lucite reinforced. And to just go into a bit of the physical properties, you have, so the material, or that this particular material is crystallized, resulting in formation of lucite crystals. They make up 35 to 40% of the volume. And this results in a toughening or a crack deflection toughening mechanism. The flexure strength of these of the lucite reinforced comes to about 160 megapascals. They can have high or low translucency, but those who have used CEREC, the material would come as Empress card or Empress card multi. Uh, the other glass ceramic is lithium disilicate. And this is made up of lithium disilicate crystals, 65% by volume. You have moderate strength, that is 450 to 550 megapascals. They have good translucency, They have high wear resistance and moderate tooth wear induction, as opposed to the feldspathic porcelains. And just like the feldspathic, so they can be bonded, or you can etch the sub and bond them to the tooth surface. And this has been marketed significantly as Emax card by Ivoclar Vivadent. And this material, the lithium disilicate, satisfies both occlusal stress and aesthetic demands, which means it can be used for your veneers, for your onlays, and anterior or posterior full crowns. Most of us are familiar that this is available as card-cam blocks or ingots for pressing. And they can also be used for high opacity for copings if you have discolored preps, so remember that. And they can be layered with porcelain or monolithic. What does that mean? You can cut back, so you can actually just have a core of lithium disilicate, and then you build up the back of the facial aspect using your feldspathic porcelain. That way, you're able to maximize the strength of the lithium disilicate and the aesthetics of the feldspathic porcelains. So that is something that you can always ask your technician to do, but can be done just with the lithium disilicate, or you can choose to layer it. And most of us are familiar that the way this is processed, the Emax card is partially crystallized. So that allows the manufacturing process to be easy, that you can cut it with rotary cutters. And then after that, you can sinter it so that you get full crystallization. Then we have zirconia reinforced lithium disilicates. So you just have the disilicate plus zirconia dioxide, which results in improved flexure strength. And you're talking about 540 megapascals. And this can be used, it has the same applications as the lithium disilicate. For your anterior and posterior full crowns, partial coverage is your onlays, your three-quarter crowns, and the veneers. And you have both the translucent and the high translucent versions. And they're available as card-cam blocks. And here, I think because there are different companies that are selling different products, this, I believe, is a German company, Vita Suprinity, or the brand is Vita Sunfabric. So what are the pros and cons of the glass ceramics? So they are highly aesthetic and have a natural appearance. They are metal-free, so no allergy like the metals. They are biocompatible and durable. They are versatile. They can be used in different areas of the mouth. They can be used for different restorations, and they can be etched or bonded. However, their strength, because it's just moderate strength, that can be an issue. So there are limitations. And you need to be mindful if you have a dark prep when you're using these materials, because this could be your undoing. You do a beautiful crown, but because you forgot to tell the lab to put an opaque layer in there, when you come to cement it, all that is showing through is the dark denting, and that can throw off a patient. So these are things that you should be mindful about as you develop clinical skills. What can I do? Be mindful of that. So in some cases, you might need to take what they call that stamp shade. So when you do a prep, you need to record the shade of the prep in some cases, especially if you're doing aesthetic work. Then you can ask your lab, the shade of my prep is this. But my patient wants this kind of shade. What do I do? So if you're working with a good lab technician, they should be able to advise you We can put an opaque core, but when you put an opaque core, you're going to sacrifice the translucency or the natural appearance of the crown that you're doing, especially if you're working at the front. These materials are abrasive and they can, of course, cause potential wear of the opposing dentition. And compared to the feldspathic, you need to do more tooth reduction. So let us discuss the polycrystalline. So the other two materials that we have discussed in ceramics have a glassy phase. That is your physics, the crystals and the way they are. When you're talking about polycrystalline, there is no glassy phase. All you have is a crystalline phase, which of course improves the strength of the material. And originally, the dominant material in this particular group used to be called alumina. However, it has been superseded by zirconia. But for our sake, we're going to just discuss the alumina briefly and then zero in on the zirconia. So alumina was made famous. It's a brand made famous by Nobel Biocare, and the brand was called Procera. But even now, Procera has shifted to zirconia. So it's no longer doing alumina cores. It is doing zirconia cores for its work. This is highly aesthetic. It can be layered and can be used for your single or multi-unit tooth or implant restorations. And they have high flexure strength, as we shall discover in the next slides. This is for historical purposes, so the chances are high that many of you will never use or will never have work that has an alumina core, because right now most of the work is based on zirconia. So let us talk about zirconia, which is of course the in thing for most of our work. And this can be divided into high strength polycrystalline ceramics. And all this is based on the amount of a component called yttrium. Based on how much is within the ceramic, that determines whether it is high strength or translucent polycrystalline ceramic. So you have the high strength ceramics have a high flexure strength of 900 to 1300 megapascals. They can be used for single crowns or to multi-units. And they, of course, are available as partially sintered blocks for CAD/CAM milling. The translucent has a high content of yttrium. The major drawback of the major drawback of polycrystalline ceramics is that they have high strength but low translucency, which is a major drawback for aesthetics or for anterior crown and bridge work. So in order to try to get advantage or to get the advantage of the strength, they have tried to add things in the polycrystalline ceramics to improve the translucency. And that's why you have the translucent polycrystalline ceramics. But their flexure strength is reduced, not significantly, can be used for the same or has the same applications as the high strength ceramics. And you have them coming as mono or multi-chromatic blocks for CAD/CAM milling. So normally when they add, that's the highly translucent, the translucent polycrystalline ceramics, the volume of yttrium is increased in these materials. So they come as partially stabilized zirconia, and you can use it for your full mouth reconstructions. So the advantages are that you have high flexure strength of 900 to 1300 megapascals, high wear resistance, low tooth wear induction, so they can be used at the back without any issues. They employ CAD/CAM technology or milling, and they have a property which I'll discuss in the next slide called transformational toughening. Of course, because they are also thin, they're strong in thin sections, you don't have to do a lot of axial or occlusal tooth reduction. They can be used in a number of applications. They are biocompatible, and this is where most of the research and development in modern dentistry is. Limitation is they're not etchable, they are brittle, and of course, they're not as aesthetic as the feldspathic, even the glass ceramics. So zirconia, one of the advantages that it has is the property called transformational toughening. So when it develops a crack, if your material develops a crack, the property that this material can arrest the crack. And how does it do it? So around the crack or the tip of the crack, the material transforms from the unstable tetragonal phase to the monoclinic. And when it transforms into the monoclinic phase, it causes a volume expansion of about 3 to 4%. That expansion generates compressive strength or stress. It is that stress that arrests the crack. So it stops the propagation of the crack. That is, I think, a beautiful property for a material to have. That way, and because this is being worked on and developed over and over, I'm certain that in the past people were saying these restorations are not good, they fracture, they break. Down the road, these will be non-issues because of the amount of research that is taking place. So I would use this material wholeheartedly in a Braxa. Of course, you have to take care to limit the damage that can be done by doing either night guard or whatever needs to be done to protect the occlusion. But you can wholeheartedly, or you can, without losing a night's sleep, prescribe this for your posterior restorations. Of course, people are looking at trying to maximize or combining your polymers as well as the ceramics. Because such materials also have advantages. They have combined advantages. You have polymeric properties, and that basically alludes to elastic modulus of materials that are like dentin. So basically, this tooth is going to flex or to bend like dentin, which is less stress on the tooth structure. And so the material, the abutment won't fracture or won't undergo unnecessary stress. So this is a cutting edge research. That's where people are headed, that how can we combine the good advantages of polymers as well as the aesthetic advantages of the ceramics. So these materials, what they are called polymer infiltrated ceramic networks, satisfy both aesthetic and chemical stability of ceramics. However, the flexure strength is still low, and the company that's spearheading this is Sunfabric. I think it's a German company, and these materials can be used for anterior and posterior crowns, your partial coverage, and veneers. And like everything in these days, they're available as CAD/CAM blocks. So what are the pros and cons of these polymer infiltrated glass ceramics? So of course they're able to resist cracks, they're pretty lightweight, and they're biocompatible. However, we're limited in long-term data, and they are abrasive, and they're not as translucent as your glass ceramics. So I thought, just for the uninitiated or for the person who's not familiar, just give us, I've talked about layering, CAD/CAM blocks, and pressing, just to give you an idea of what this is so that you have an idea of it. So layering is where you have somebody actually building a porcelain in different layers, the dentine, the opaque, and the enamel shade, the incisor shade. That is, so it's highly technique sensitive. So you need a technician to do this for you. But the work that comes out of here is beautiful. So it's your ultimate aesthetic potential. However, it's time consuming. And the world has moved. We want things that are a little bit faster, predictable, you can do without training a lot. So CAD/CAM layered blocks are the thing to go to. You don't need to be a dentist to do this. All you must have is a good program, and you can operate it, and you can mill your crowns. However, there are pros and cons to this process. Some people say you end up having a lot of open margins if you're just simply leaving it to a machine to mill without any personal input to the process. But we know they are low technique sensitive, there's limited aesthetic potential, but they're time saving. And it makes sense for you to invest in this. I think that's where the world is headed. So you can either bury your head in the sand and say you won't get there, but that's where it's headed. And things are getting cheaper. You have milling machines that cost a lot less. You can buy for $390. So if I were you, if I was advising you, this is an area we shouldn't ignore. We should see how can we use it. How can we maximize the developments that are taking place in this area for our benefit? Uh, because you can do temporary crowns. I mean, there are lots of applications you can do with this, and it's pretty cheap. So of course, things are not where they should be, but it is something that I would not wait for too long to adopt. If time and finances allow, I think it would only be proper for us to head in this direction. Then you have the pressable. The pressable still follows the old system of the lost wax technique, that you have to wax up the core or the crown, and then your ceramic is melted and pressed in there, and then you get your crown. So that is what basically you can do for all the ceramics nowadays. They're pressable on top of CAD/CAM milling. Yeah. So I think now let us go to the clinical powers. What are the takeaways as we come to the end of this presentation? What are things that I think that you can use or that you can adopt in your practice? Many of us know that the TMJ, the teeth, a class 3 lever system. And if you remember your physics, that has the least mechanical advantage. So basically the mouth acts like a nut cracker. You have your fulcrum at the end. You have your load in the middle and the effort at the front. So this is not mechanically advantageous in any way as opposed to your class 1. So that said, you need to know that at the back, you need high intrinsic strength. At the front, not so much. Uh, in that regard, if you're designing restorations or if you're choosing restorations, you should use zirconia at the back, perhaps lithium disilicate in the middle, and then your feldspathic porcelain at the front. But you're trading one thing for another. as your strength increases towards the back, the translucence decreases or the opacity increases. And towards the front, as your translucence increases, your intrinsic strength drops. So you need to be mindful of that. But this will give you an idea of what to use where. So if I were you, zirconia at the back, your molars. Your premolars perhaps go with lithium disilicate. And your anteriors, you go with the feldspathic porcelain. I hope this drives the picture home, that where should I use what? So briefly, let us look at what's the difference when you're prepping for, or what, if you compare the glass ceramics to zirconia, what major differences are there? So for your lithium disilicate, your shoulder margin is 1 millimeter. When you go to zirconia, you can even bring it down to 0.5 millimeter. Lithium disilicate can be grinded, but can also be milled, but zirconia is basically milled. And that's just basically because of the material. So grinding involves, so when you're grinding, it's a manufacturing process. So this whole thing about whether the machine, it depends on the material you're using and the machine that is doing the work. So some materials which are very strong, you need to be grinded because you use frictional resistance and use diamond bars. For the milling, which applies to softer materials, your polymers, your zirconia, and partially sintered materials, then it's milled. It uses rotary cutters. So it's a softer material to cut at that point, and it cuts to fine detail. And then you can do the crystallization, the full crystallization through what? Sintering. So it's a manufacturing process. Just if you have anything to ask about that, and I'm sure Dr. Tom and those who are doing a lot of CEREC work back home will definitely let you know. The occlusal reduction for lithium disilicate is more than that of zirconia. The same. So basically, you have this material which is new on the market. The major drawback is its aesthetics. But in terms of conservation of tooth structure, manufacturing process, it basically beats almost all the rest. There's a difference in the processes of cementation of these crowns. It is more systematic with your glass ceramics as opposed to your zirconia. Zirconia is just requires just sandblasting of the material of the prep of the core of the fitting surface, and then you can cement. So it's cemented to the tooth structure. The silicates are normally bonded to the tooth structure. So you have your resin, you have your etchant, you have the silane, the primer, and then you use the resin cement. Take home for your full metal and metal ceramics. Normally the surface or the fitting surface is treated for you in the lab. They'll do surface roughening either using metal primers or they're going to do sandblasting. And the cements that I would keep is your zinc phosphate or your glass ionomer or resin based. It's up to you really. So if you still have zinc phosphate, it will be good for you. It works beautifully with the PFMs and metal crowns. And just remember to mix it thin. Don't do a thick mix. Do a thin mix that will serve the same purpose. If you're doing veneers, they'll be treated with the hydrofluoric acid. That's the preparation of the bonding, the fitting surface, or what they call the intaglio surface of the restoration. Then they'll do silane application, and then you can light cure or your cure with any resin cement of your choice. The same would apply with the glass ceramics, and here I'm talking about lucite reinforced. You might use a hydrofluoric acid of a different strength, but you still wash it away, and then use silane application. Silane allows the resin to bond to the restoration, or it allows for that. That's why you silane treat the after etching with hydrofluoric acid. And then you can use your light cure or dual cure composite resin luting cement. The same would apply with your lithium disilicate. But here you're using hydrofluoric acid of 4.6%. Sometimes it doesn't matter. You might just use 8, but this is done by the lab. Mostly it's done by lab for you. But if you have a milling machine in your practice and you have an oven, so you're sintering and everything, you need to do this processing yourself. So after you have sintered, then you need to treat the surface before cementation. So that's where this comes in. So because a lot of this is not being done by the lab, but it's being done in office, then you need to know how to treat the surface before you cement the restorations. For the polymer infrared ceramic networks, you still do the same. You do 98 hydrofluoric acid, you do the silane application, you pre-treat the tooth surface, and then you light cure or dual cure composite. For zirconia, it's different. Zirconia, as we said, you need to sand. It's not bondable, it's not etchable. You have to sand blast the preparation surface. So you can have a small machine in a sandblaster, basically a gun that can treat the surface. And then you can apply a little bit of bond, and then you cement the restoration. So as we conclude, many of us are not going to have different cements in our practices. So you can use nowadays, and many of us you can have a self-adhesive or self-adhesive luting cement, resin luting cement, like Rely X Unicem. And this material can be used for all your cementing needs. However, the surface has to be treated differently before you can use this. If you're doing a metal PFM, you have to sandblast, and then you can use zinc phosphate or polycarboxylate, or you can use any of the dual cure or self-adhesive cements. For the glass ceramic, you treat, but you can use this Rely Unicem. Even the same applies with zirconia. So if I was looking for a cement that might work across all my needs, I might be interested in a Rely X Unicem. That said, thank you for your kind attention. And I think if there are any questions, or we can open it up for discussion, I hand over to Dr. Chizito to lead us in that phase.
Thank you so much, Dr. Kalanzi. That was insightful. I mean, in the basis of materials, preparation, cementation, and the rest that's pertaining to crowns and bridges. So thank you so much for that. I won't take so long. I think we can ask any questions either through the chat or even unmuting yourself. You should be able to ask those questions. As we do that, feel free to go on whether with the chat or unmuting. But I'll ask the question that Dr. Ntulume put up. He was inquiring the safety of dental prosthesis with MRI scans. I think now that we're getting people who need to have MRIs, they're questioning what materials should be a concern, including implants, metal prosthesis, gold and base metal alloys, and all that. So what is your take, if you have any idea of what we should be having for MRIs?
Mm, I can't say that I have. I don't know what the literature says, but I am of the view that these materials have been used over and over and over again. And remember that sometimes MRIs can now be selective. It depends on which area of the body you're interested in. It might not be a full area to put the person through an MRI scan. So, but I don't think there's any absolute contraindication. Titanium prosthetics have been used to replace joints for a long time, and there's been no literature suggesting that's contraindicated for MRI. So I'm of the view if you really need to zero down, I think I would go more for titanium because there would be no issues. But I don't think any other materials have that much issue. The problem would be reading findings, especially if the findings are revolving around head and neck, or because the way that the materials cast or show on the films can easily alter your diagnosis or can easily cause what are they called?
Shadows.
I
Well,
forget the term that they use, but what I'm saying is that it can easily confuse or make your reading unclear, especially if you're interested in pathology of the head and neck region. That would be my take.
okay.
So in that case, they would
Oh,
you'd have to request for another investigation.
okay. Dr. Antony may still adding that those would be artifacts maybe
Artifacts,
in
yeah, we could
the
add
reading. Yes.
artifacts, yes.
Yes. Just to add to this, I think the current materials are having a lot of research with regards to that, especially with titanium. Titanium is very safe for MRI. The concerns came in with gold and base metal alloys that are used for crowns, but I think so many people have had crowns and they've gone through MRIs and
Yeah,
not had any issues. So,
any issues, yeah.
um, but there's several articles that I read up one on titanium, but I could look up any others and I can share with Dr. Ntulume on that.
Mm.
All right, so Dr. Mobali is thanking you so much for the presentation and is asking, Dr. Kalisul, I'm coming back to you. I know your hand is up, but then let's answer Dr. Mobali, then we'll come back to you. So Dr. Mobali is asking for what's the best finishing after chairside adjustment, or what material offers the best finishing after chairside adjustment in the whole array from metals to ceramics.
So I guess it depends on what you have in your store because right now the manufacturers can offer different finishing material, whether they're diamond abrasives or you can get a polishing kit for whichever material you're working with. In fact, nowadays, what do I hear in the past? Now, it's not so much, they don't actually want, in the past, they would do glazing to give you a very
Yes.
good finish. But nowadays, glazing is being discouraged. You don't need to glaze ceramic restorations. They are finished so well that glazing actually would just make things worse. So I know I have read that they're discouraging glazing because the material can be finished pretty well with a number of polishing discs. So all you need
And
is
also actually
to get a
glazing adds another thickness
yes.
to any prosthesis. So when you try it in and then you go back to glazing, you'll actually get another one 0.5 millimeters, which will add to your again, you have to remove it, which is a
Yeah.
nightmare. Yeah.
So
Yes.
what I would say, whether it's a metal or full metal crown or FPD, is that you invest in a polishing set of discs. These are normally they can be slow speed driven, but they are now cut. They will give you an excellent finish. So after you've done your closer adjustment and you just want to give it a final luster, the manufacturer will tell you in which order to go with those different discs so that you achieve the same luster as if the material just came back from the lab.
Okay. Dr. Kalisula, I think your hand has been up, so you can go ahead with your question.
Yeah, thank you very much, Dr. Chizito. Thanks very much, Dr. Kalanzi, for presenting that well-researched literature about these materials. My interest is in partial coverage crowns.
Yes.
Late, I think it's becoming trendy to preserve enamel. And so it's really, really critical that the whole tooth should go, especially the vital ones. Then a partial coverage crown comes handy. What has your experience been with either onlays or inlays? How do you temporize them? What cement do you use for temporary crowns? And are you probably milling them or printing them? And so what material are you using to cement them? I had some challenges with the zirconia partial coverages because I think the cements are not quite strong and they tend to debond in use. So kindly give us some information about the partial coverage crowns with regards to the materials that you've shared. Thank you.
So partial coverage, in my experience, I've not done many because in most cases you end up really, you'd rather do a full coverage. So partial coverage would be onlays, and also it depends on how many cusps have been lost, or if you have such a huge restoration, especially amalgam, and then one of the cusps fractures, then a partial coverage crown would be a good indication. And that can be in the past, they used to be gold, but because gold is not aesthetic, because now want to be natural, want to have the natural appearance. So you're going to do your lithium disilicate. So if I was doing lithium disilicate, then remember it's going to be bonded, but your prep also has to be minimal, or you have to factor in retention mechanisms as well. And then if you're going to bond it and if you're bonding to dentin, then you're going to have issues. But if you're bonding to enamel, then it's going to be excellent. So that is something that you have to make a choice. I'm certain that even zirconia can be used for that. It's just knowing what cement to use and how to use it. Just sandblast the surface. You can apply a thin layer of bond on the tooth preparation, and then you can use your self-luting resin. In terms of temporary materials, definitely, that's what I'm saying, that a person can invest in a printer, which is, they're very cheap. And now they're making composites. They're researching different materials that can be used to make temporary crowns, to make long-term temporaries, or to make inlays or onlays. So then if I were you, I would invest in a printer. But the materials are not yet there. So they discolor over time, they change. So unlike the ceramics, that's an area of active research. But I am certain that 3, 5, 10 years down the road, an early investor in a 3D printer or in their office will definitely be far ahead of others because the applications are numerous. It's just the mind that's limiting us to what we can do. Normally, when I'm cementing temporaries, I sometimes, based on what the final material is going to be, if I know I'm going to use a resin, then I make sure I use non-eugenol containing temp bond. Because studies have shown that if you use eugenol containing temporary cement, it tends to infiltrate the tubules and it's going to affect your final bonding with the resin cement. So that would be the thing. But sometimes in clinical practice, and that is me, if my temporary locks in place, I do not remove it. So I tell the patient I haven't cemented it. I think it locks greatly in place. And if my crown is going to be back in 2 or 3 weeks, I would let the patient go and without doing any cementation. That will be my take. I hope I have covered all the questions that have been asked.
Unless a tooth is vital, because if it is, then we'll get sensitivity.
Yeah, but sometimes
Or would you still do the same
it looks so
if it's vital?
it looks so well in place that if the patient is not complaining of any sensitivity, I don't, because the trying to remove it and then trying to cement it it's tedious. So, but everybody has a different take on how they do certain things.
Okay.
But the bottom line, if you want to use a cement, I would suggest that you use a non-eugenol containing or eugenol-free temporary cement.
Okay. All right. Thank you so much. Dr. Osman is asking, thanking you so much first for the presentation. And he's asking for your opinion with regards to what's the maximum number of units that can be made using Emax, or rather using zirconia for a fixed partial denture.
I think you joined us late, but I said that there's a systematic review that has shown that you are safer off having a metal core even when you're using zirconia to build. So right now you can use titanium as a core and then you build your zirconia on top. That way you are not going to get catastrophic failures or fracture in a short while. So I can't really. I know many people can use it for full mouth reconstruction. So that means you can do from 1.6 to 2.6, or from, it depends, or 1.7 to 2.7 without any issues. But the studies have shown that you are safer having a metal core as opposed to having zirconia and ceramic only. So just be mindful of that. So it might fail in one patient, but may not fail in another patient. So just be mindful of that. That's what I would say.
Okay, interactive, I'm happy about this. Dr. Patience is thanking you so much for the presentation. She's asking if we can bond zirconia with MDP-based cements.
Zirconia to, so you use what? You use a zinc polycarboxylate?
Saying MDP. Dr. Patience, I don't know what that abbreviation is, but I just want to be sure. Maybe Dr. Patience can explain the MDP part.
Yes. Metal based, I don't know. It's metal based. I don't know.
Hi, sorry, I'm in a bit of a loud place.
This
the full name is methacryo something diethyl dihydrogen phosphate, but it's a silane that you can add on sort of after working, so that it's supposed to bond. Yes, the silane.
The coupling agent.
Bonds, yeah, it's coupling agent that bonds. So does that mean that we can bond zirconia, or it's still cemented?
No, zirconia is cemented. However, the research has shown, that's why I told you that sometimes if zirconia, what you do when you sandblast the fitting surface, you can apply normal bond, the bond that you use for bonding resin composites, onto the prep. And then you can use your luting cement. That combination tends to give better results than simply without using bond. I think that's what she meant, if I'm correct.
Yeah. The silane coupling agent.
So it's not a silane coupling agent. You can just use it.
No. Guys, it's a silane that sort of bonds to the zirconium oxide. So you're actually bonding the zirconia. But I stand to be corrected if I'm wrong.
Because the biggest problem with zirconia is the fact that because it's not etchable or bondable, so you cannot silane it. So whatever, they're trying to find so many materials that can link between the zirconium dioxide and then, or the zirconium dioxide and the bonding agent, which is usually a resin. So there are so many materials that are coming up that are used for that. And so that's one of them. Okay, sorry, I didn't go to the MDP part, but that's one of them. But still, if you don't sandblast it, you're not going to get any adhesion to the tooth. But there's so many other, like Dr. Kalanzi said, I mean, this is research. It's research and development, especially in ceramics. That's where all the work has gone in fixed partial dentures or even restorative work, fixed restorative work, and implant-supported prosthesis. Everything is going in that direction. That's why I wanted us to listen to, or to see how best we can discuss this. But there's so much going on. And I think, Dr. Kalanzi, I don't know if that's where you're going, but yeah, that's something that's happening a lot. Okay. All right. So we're going to look at the beautiful presentation, 3/4 crowns. I think someone, Daniel Senteza, is asking, would you be worried about ammonia compounds in dual core that may affect the bonding of these crowns? In dual, I think this was dual cured resin cements that would affect the bonding of these crowns. In other words, what's your mainstream cementation material for preparation-less or minimal preparation veneers? I think you had talked about that, but you can just reiterate that.
Oh, because here what you're doing is you are maximizing the etching properties that enamel gives you. That is for prepless. So where you're just putting the margin, you are depending entirely on the enamel. And if when enamel is etched and then you use a resin cement or you bond it, the chances of it coming off are very minimal. That's what you're depending on. So you're not using anything else. You're depending on the ability to etch the enamel. So if I'm doing a prepless, then you must make sure that you just need to roughen your enamel to just open up more pores for bonding. That's where I would go with that.
Okay. All right, he's still asking for what your mainstream material would be, cementation for veneers.
Oh, now it depends on what you are, but basically you're looking at a resin cement, and this one you might go for either light resin. It will be a resin cement. Now it's up to you whether it is light cured, dual cured, or self-adhesive. It's really up to you. If it were me, I would want the total etch process. You etch, you bond, you cement. But some people are okay with the self-adhesive. My preference is total etch.
Okay. All right. So I think the last one, have you attempted, this is Dr. Mlondo asking if you've ever attempted to use flowable composite as a cementing agent for zirconia instead of a resin cement, I think.
I haven't used it, but if he has used it and it works, I wouldn't fault, but that is if you don't have theoretically, I think it would work, but the way it is developed, it's not developed as a cement. So you don't want to fail. You don't want to court failure so early in the process. So I would rather invest in something that can give me a thin film, yet cement the tooth.
I would also worry a lot about the cementation. I mean, if it's going to be light cured, like all resin cements, then if you're putting it under zirconia, which is opaque, then you're going to have issues with most of the cement not light curing, or most of your composite not curing or not hardening, instead of using a dual cure cement, which would be good for a zirconia. Okay, I think this is the fastest we've finished a CDE, and very well attended, I must say. So thank you so much, Dr. Kalanzi. That's been, seems everyone was happy to see you. I'm seeing so many messages about that. So that's amazing. I don't know if there's anyone who has a question with regards to our topic today with the choice of materials for fixed partial dentures and crowns. Please feel free to put up your hand or to communicate. But if you don't have any, we're good to go. Dr. Kalanzi, I'll let you enjoy your morning. Thank you so much.
Have a good evening and enjoy your weekend.
All right. Okay. Everyone else, see you in next week, actually, or the other week for next week for the AGM. And then please register for that. The other week, we'll be doing another series in our fixed prosthesis. So I'll wait to see you then. Okay. All right. Thank you so much, Dr. Kalanzi. And to everyone, enjoy your weekend.
Okay.
All right. Bye-bye.